for this session, I would like to welcome Professor N.R. Das. He is Senior Professor Surgical Gastroenterology from AIIMS, New Delhi.
I welcome you to this session on the role of staging laparoscopy in managing the incidental gallbladder cancer. We have already discussed that the incidence of metastasis in the cancer in incidental cholecystectomies are about less than 1%. To be precise, about 0.35% at an average per article. The dissemination rate in these patients are to the tune of 2 to 10%, and the local advance status of the disease at the time of re-exploration is a little bit higher than that. This may be around the tune of 20%. The available imaging modalities which we are having, we know that they are not so capable of picking up this dissemination or locally advanced nature of the disease, and the sensitivity and specificity is very limited. So only thing left for us in the armamentarium is the diagnostic laparoscopy. So to discuss about it, I would like to invite Dr. Saurabh. He is a colleague of mine, and he's associate professor in gastrointestinal surgery in AIIMS, New Delhi. So Dr. Saurabh, please.
So at the outset, I really want to thank all the organizers and my mentor, Professor V.K. Kapoor, for giving me this opportunity. Staging laparoscopy in incidental carcinoma gallbladder. We all know the incidence is around 0.2 to 1.1% of all cholecystectomies, with various studies quoting that. Re-resection can depend upon the stage of the disease, the patient factors, and we know that the unresectable disease can be there at the tune of about 20%, but this includes both the locally advanced as well as the metastatic disease. Staging laparoscopy basically is employed to initially find out the metastatic disease. There's a need for an extensive preoperative workup in these patients because we do not want to subject them to another unnecessary laparotomy. So we can do various investigations like markers. We can do all the imaging armamentarium that is we have, that is multi MDCT we can use CE, MRI, we can use FDG PET. And one question is, what is the role of staging laparoscopy in the era of minimal invasive surgery? That is, now we are propagating that we can actually do the minimal invasive surgery in the incidental carcinoma itself. So, but still there are many centers where actually this expertise will not be available, and still open surgery holds true, and probably a staging laparoscopy can at least rule out those who have disseminated disease at the outset. What is the question at hand? Is the staging laparoscopy actually required when we are subjecting these patients to surgery? Is there any specific target subset which we can formulate where actually we will propagate that these patients should undergo laparoscopy? And what is the evidence in the literature? Before going on to that, can actually FDG EVID supplant laparoscopy? So there were 3-4 studies which actually studied the role of PET-CT in incidental gallbladder cancer. This was by the American group, and there were 32 patients in which 19 had positive PET and 13 had actually negative PET, but out of these 13 also, we found that about 25% that only 4 underwent surgery, 9 actually refused surgery, but of those 4 also 1 had a metastatic disease. On the other hand, those positive, actually they had included both the locally advanced as well as metastatic disease for the positives, so they underwent a re-resection, and there also they found that 4 patients had a metastatic disease, so which means that FDG PET may not be able to pick up all the disease that is there at the time of surgery, that prior to surgery. Similarly, another publication in 2014 had 100 patients, out of which 63 were actually incidental gallbladder cancer. They actually did CT scan, MDCT and a PET-CT, and then they compared the two, and they found out what was the concordance of MDCT with PET-CT. 20 patients out of the 63 had actually metastasis. There is 30%, more than 30% had this, but those who actually underwent resection, 30% of those also had metastasis at the time of surgery, which means that the false negative rate of PET scan was still very high. And I think very recently a paper by Shivendra Singh sir is also there, that although there is change in management in patients, but there are patients where actually the PET can miss disseminated disease. So maybe staging laparoscopy does have a role. Looking at the technical aspects initially, what are the areas we usually inspect? So those are liver, gastrohepatic ligament, the whole of the peritoneum if possible, porta hepatis, and pelvis. We put in additional ports. So we can see we can initially put a primary port. Sometimes it can be away from the umbilicus also, because if the patient is coming to you later on, you can suspect adhesions at the umbilical port which was initially used. And additional ports can be in the anterior axillary line or in the epigastrium, so that you can take a biopsy, or if required, some amount of adhesiolysis if possible. And whenever it is possible, we can do a use of a laparoscopic ultrasound, and any suspicious lesion should be biopsied. And some of the, I would say these are some of the pictures which usually you get peritoneal metastasis. Large metastasis usually, if this big a metastasis usually will be when the patient has presented very late to you. So what is the evidence for staging laparoscopy? So initially in 2002, Weber et al. Had a study for gallbladder as well as high local angiocarcinoma. Total 100 patients were there, out of which 44 were gallbladder cancer. And they found out that on the staging laparoscopy, 21 patients had metastasis. But the subset of incidental gallbladder cancer was very small. Only 10 patients of gallbladder cancer had incidental gallbladder cancer. And you see that the pickup rate of staging laparoscopy was much lower in incidental gallbladder cancer, to the tune of about 20%, as compared to when it was a primary gallbladder cancer, which was about 56%. But this is probably because this could be early disease that the patient had come, and already these patients who undergo laparoscopic cholecystectomy, half of the examination has already been done if they are coming early to you. Then there was a multicentric study which was published in 2007 by Pollock et al. 6 centers were there, out of which IGBC was for 148 patients. For the study, they included only 115 patients who underwent resurgery, that is 78% of the cohort. And the time to resurgery was about 52 days. But they found out was about 16% patients who had undergone a staging laparoscopy were actually inoperable due to liver or peritoneal metastasis. So a big chunk of patients could actually, we could avoid exploratory laparotomy, and this is as early as 2007, that is 16 years from now. Then in 2011 came one of the studies which has been used in probably all the papers if you go across for staging laparoscopy. That is a study by Jarnagin et al. In where 136 patients of incidental gallbladder cancer over a period of about 11 years were taken, and they found out that the disseminated disease in their cohort was actually very small initially. That the 46 patients who actually went for surgery, only 2 had disseminated disease at the time of staging laparoscopy. But out of those, when the 44 patients were then further subjected to exploratory laparotomy, 7 more were there who actually had metastasis, which was initially missed on the staging laparoscopy part. Actually, this was because they had done some sort of a staged procedure. They hadn't done it as a primary procedure and then went on to the exploratory laparotomy, but rather as a staged procedure. But they postulated few factors for where actually they postulated that there was higher chance of having metastatic disease, and these was higher T stage, that is T3 and above, any positive margin R1 or R2 resection at the time of index surgery, and the poor tumor differentiation. So these 3 have been postulated, and if you will go across, as I'll show in future slides, all the consensus statements eventually include these 3 subset of patients for staging laparoscopy. Then came a big study from India, Agarwal et al., 409 patients of carcinoma gallbladder for across 6 years. Total 773 patients of gallbladder cancer, out of which 507 were operable, and 98 was incidental gallbladder cancer, and 409 were primary gallbladder cancer. The biggest takeaway from this study, actually, total 95 patients had a disseminated disease at the outset itself. But even in the primarily resectable disease, there was 18% of patients who had actually missed disseminated disease. But there was, the findings were that the unresectable disease the accuracy of staging laparoscopy was only 55%. That is 45% were actually missed even after staging laparoscopy. But the specificity, that is the accuracy for the disseminated disease, if they postulated it is disseminated, then it is there, is 94%. And so one thing you have to look at is that the analysis actually excluded the incidental gallbladder cancer from the where the patients, those who were analyzed, were actually not IGBC, but only primary gallbladder cancers. So I tried to look at the early GBC, and we found that even these patients, which could actually be closer to the incidental gallbladder cancer, even they had about 9% of disseminated disease, which was picked up of staging laparoscopy. So which could be actually extrapolated to our subset of patients, that staging laparoscopy actually does help in these patients. Then came the first consensus statement in 2015, and it postulates that staging laparoscopy is recommended in patients of IGBC, and predictors are, as I initially postulated, initially elaborated T3 and above stage, poorly differentiated carcinoma, R1 and R2 resection in the index surgery. Then after this, so these three, then came a position paper from ICMR, and all the stalwarts are actually part of this group, and the recommendation was the staging laparoscopy is recommended in all patients undergoing primary surgery with intention to resect, and may be of use in patients with the diagnosis of incidental CAGB prior to going ahead with radical surgery. Although FDG PET is not routinely recommended, it may be used if available prior to the radical surgery. So this was a consensus statement given in the position paper of ICMR in 2015. And recently in 2020, a Brazilian consensus was there, which was from the HPB only. Similarly, it also recommended that any patient of T1B and above should undergo a staging laparoscopy before the gallbladder cancer reoperation, and potential of detecting the metastasis may be higher due to delayed presentation and risk factors such as bile spillage and presence of positive margin as well as high-grade tumors. And as you can see, the agreement is at to the tune of 97%. That is, most of the experts actually agreed to this statement. Then there was this paper from SGPGI, which we were previously discussing for the timing of referral. They also had total patients of 91 patients of IGBC, and where they found that even different times of presentation did not actually influence the presence of metastasis. As again you can see, although they recommended that intermediate group is the one where actually surgery is recommended, that is 4 to 12 weeks. But there was higher incidence of metastasis also in these patients. It was all the number as compared to early group. So this is one thing which could be actually contradictory to what they are recommended as far as the timing of the reoperation is concerned. Because when more metastasis there is less likely that you are going to actually do a better job. Then this is the National Cancer Group draft guidelines from 2021, and this is for the incidental gallbladder cancer also. Only thing I wanted to highlight was that diagnostic laparoscopy, if presenting after 4 weeks prior to the definitive surgery, should be taken into consideration. Finally, this is the very recent paper by the Netherlands group, and they have taken 107 patients, out of which only 7 patients underwent staging laparoscopy, but there also one patient was found to be unresectable. But unfortunately, the 6 patients which were found to be resectable at laparoscopy, 2 were still found to be unresectable. So although staging laparoscopy does pick up disseminated disease, there are fallacies in staging laparoscopy, probably sometimes because we are not able to do a complete job. We are not able to see all the areas of the abdomen where the disseminated disease might be there. But still, at least some of the patients, we can avoid negative laparotomy per se and send them to for the palliative chemotherapy if possible. This is finally, this is a small study from AIMS actually. This I kept in end because this is, although it is just a retrospective study and studied 54 patients, did not undergo staging laparoscopy. Only thing I wanted to highlight was that the operability rate was only 65%. The 35% patients actually did not undergo surgery. So they must have undergone a negative laparotomy, which could, some proportion of which could have been avoided if a staging laparoscopy was employed at that time. So my take home from all these evidence is that staging laparoscopy should be done in patients undergoing resurgery for incidental carcinoma gallbladder. We can use additional ports if required so that we can do a better job. Biopsy any suspicious lesion, and laparoscopic ultrasounds, if available, should be used so that we do not miss an intraparenchymal hepatic metastasis which might be there. Thank you.
Thank you, Saurabh. Comments from Dr. Shivendra Singh, please.
Good afternoon, everybody. I think Saurabh has covered most of the top points, and I will be focusing more on the technique part. As you can see, all the laparoscopy, staging laparoscopy studies have included both the overt gallbladder cancer and incidental gallbladder cancer. And incidental gallbladder cancer studies Saurabh has covered. So how we should do the staging laparoscopy, I will be using. At least you can use a 5 mm, 10 mm, 30 degree laparoscope. Better to use at least 2 to 3 ports, not a single laparoscope, single port laparoscopy. And preferably to place the ports in the line of future incisions so that you can excise them later on. And always look for peritoneal omental deposits, liver mets, if they are present, do the frozen sections. Always look for, in the incidental gallbladder, look for evidence of spillage like the spilled stones, because they might be indicator of spillage. If ascitic fluids is there, then you should do a cytology. Usually these are the two common incisions that are being used. If you are doing a umbilical port laparoscopy, then one should place the ports along this incision. That is preferable. This is standard recommendation for all staging laparoscopy if you are doing for peritoneal disease, in diseases which are prone to develop peritoneal mist, because they have chances of tumor spreading. So the incision should be, the port should be along the incision line. So this is one of our patients. You can see this is the laparoscopy. This is not the incidental, just to show the, once you do, look for the gross where all the disease is there, all the quadrants. After seeing, then you should always look for the omentum, and pelvis also one should look. Go deeper into the right suffragette space, because these are usually the missed areas which can usually miss if you don't do carefully these areas. Look for mets in these areas. Always never miss even a pelvis, because sometimes a small fluid might be there or small deposits might be there. And once you have done seen all areas or quadrants of the disease, then one should again focus to look for the right upper quadrant. That is the most commonest site, and this needs usually a put another scope so that few areas in the liver are hidden. Those is segment 7 and 8. These are usually not easily accessible on these single laparoscopy ports, and also the inferior aspect. So one should put another post must, just to see that like this there is some small suspicious you feel whether some nodularity is there, whether no surface irregularity is there. If there is something is there, then one should biopsy it. And that is why you press this and try to look as much segment 7 and 8 as far as possible, and also the right dome of diaphragm you can see once you press the lever down. And this should be done in all cases. Once you have seen this, then one should look for the inferior aspect, lift it, because these are also the inferior in segment 7, you can see the inferior part. Also the segment 2 is also the commonest site to miss, so one should lift the left lobe, so see for segment 2. This is another patient, you can see this is a post-PTBD CAGB with jaundice, and we have placed another 2 ports, and in this once you see there doesn't appear to be any disease as such. And if you don't do it, if press it, there is some suspicious, and once you press it, then you will appreciate. So this is the disease. You can see once you press it, they will find your peritoneal disease. So these areas are usually hidden. So one should always do either 2 port or at least 3 ports laparoscopy. No single port laparoscopy should be done. So this is important to always look for right subphrenic behind segment 8-7 lesions, parenchymal, inferior segments of segment 2, or the deposits over the girotas. Many times when post-cholecystectomy, there might be evidence of spillage or deposits in the girotas. But only or other problem is if it is a post-open chole, sometimes you will not be able to access whole of the quadrant unless you do adhesiolysis. So always we do a peritoneal lavage cytology. If we find that the disease has breached the serosa, one should do a peritoneal lavage also, send it for frozen. Look for previous port sites also, because there might be small deposits, or these, if you are a believer in ports are excision, that will help how to excise these ports. Lab intraoperative ultrasound can help you in identifying intraparenchymal liver mets. If you can do an intraocular lymph node biopsy also laparoscopically. This is the landmark paper from GB Pant by Professor Agrawal, and this showed that it avoids unnecessary laparotomy in around 23% of patients. Only thing is this is the pre-PET era, so most staging was only done by CT scan of chest and abdomen. So this we published our experience of PET, how it changes the staging, and it showed that it changes the management in around, additional findings are seen around 30.9% and changes in management around 23% of patients, more so in the locally advanced gallbladder cancer as compared to upfront resectable. But in upfront resectable also it changes management around 12%. And false negative was 15 patient, that is around 12% patient, still you will miss, and that will be detected on laparoscopy even after doing a PET scan. So this was the breakup. And this is now we have analyzed our experience after January 20 to 23. 142 GBC were taken off for surgery. 117 were underwent radical cholecystectomy, no mets, with a resectability rate of around 82%. Inoperable was only 25, that is around 17%. And out of which the peritoneal mets were in 16, and out of which 14 were diagnosed laparoscopy, 2 were still missed, and they were detected on laparotomy. 4 liver mets were seen, and 1 was diagnosed laparoscopically, and 3 were on laparotomy only, and 5 was locally unresectable. So if you see, the yield of laparoscopy in earlier stages was around 38 to 62%. In GB Pant stage it was around 23%. So the yield is less if you do aggressively in pre-operative investigation by using laparoscopy, but still it is relevant. And this high resectability rate could be used because of use of PET in all patients, or because of use of NSCT and aggressive surgical approach, and staging lab prior to NSCT in all patients in our center. This is for a staging laparoscopy for locally advanced patients who are undergoing neoadjuvant chemotherapy. What is the finding? So we took up around 42 patients in last 3 years. There was no mets in 31, 9 were peritoneal mets which were diagnosed on laparoscopy patients. Instead of single port laparoscopy, multi-port staging laparoscopy should be done, and always look for the hidden areas. Peritoneal lavage cytology might be helpful, or laparoscopic intraoperative ultrasound might add value to the staging laparoscopy. Thank you.
Good afternoon, ladies and gentlemen.
He is
we
there
delve
online
into the
also. I
intracranial
welcome.
role of gallbladder cancer, condition that possess a unique challenge in diagnosis and treatment. Our focus in the indispensable role of laparoscopic staging and the presence of positive lymph node infestation, the celiac, the SMA, and the orthocava, to help to navigate this complexity of this disease and optimizing patient outcome. So building on this foundation, a recent review by Mohammed Saidi strongly recommends staging laparoscopy before resection, especially in all cases, with emphasis in patients with specific characteristics like including T3 tumor, polyunsaturated of lap in incidental cases and non-incidental gallbladder cancer. On one hand, laparoscopy, 19 were found to have disseminated disease preoperatively. He does make the difference between non-incidental and poor prognosis, as it is, for example, acute cholecystitis, perforation, the role of laparoscopic staging in gallbladder cancer. Beyond its diagnostic utility, staging laparoscopy significantly impacts treatment decision and prognosis. The results indicate that the yield of staging laparoscopy in incidental gallbladder cancer, specifically, and the entire population is relatively low, and the case with incidental gallbladder cancer. Consideration of staging laparoscopy is most appropriate in patients with non-incidental gallbladder cancer, and incidental gallbladder cancer with disruption of the gallbladder wall during cholecystectomy, as acute cholecystitis, T3, positive resection, poorly differentiated tumor, lymphovascular and perineal invasion, because this factor has been associated with increased risk of disseminated disease. Ultimately, staging laparoscopy is not necessary in every patient with incidental gallbladder cancer before resection. At least this is what the literature can tell us. But carefully analysis the risk and benefit of the procedure, and also incidence of the gallbladder cancer, is very important. Staging laparoscopy in countries where the incidence of gallbladder cancer is high could avoid a cost-benefit situation. I do believe that with the advancement of minimally invasive gallbladder cancer surgery, you can actually avoid this discussion, to have all patients having a staging laparoscopy and then resection by the same approach. However, I do think that staging laparoscopy is necessary. It's necessary for the risk factor we have already mentioned, and it's necessary in patients who had advanced gallbladder cancer, and you can actually see the mass of the tumor before surgery. Next, should enlarged celiac, a supramesenteric and para-aortic lymph node, should be biopsy? And if they're positive, should we stop the surgery? Well, addressing the question of para-aortic lymph node involvement, Dr. Argo compared regional lymph node positive patient with those positive with para-aortic lymph node. The data show a significant difference of overall and disease-free survival favoring regional lymph node positive patients. I know, and that's the literature I follow, is that from Professor Nagoya University about biliary tract cancer. They did found this seminal article of biliary, not only gallbladder cancer, but biliary tract cancer who had para-aortic lymph node positive. The prognosis was dismal, maybe futile, underscoring the importance of frozen section analysis influencing surgical decision. As we conclude, the evidence present highlight the complexity of surrounding decision biopsy in a large lymph node in gallbladder cancer surgery. By a study done by our group, we know that the hazard ratio of positive lymph node beyond the patuloduodenal ligament is approximately 13 with a p-value of 0.001. Although the presence of possibility of skip metastasis range from 6 to 13% in gallbladder cancer. However, this is unlikely to find as an isolated distant lymph node metastasis. And positive lymph node in a distant disease can be used as a surrogate of multiple lymph nodes involved with known dismal prognosis. The choice to abandon curative resection based on positive findings is multifaceted. In the realm of gallbladder cancer surgery, the decision to avoid the procedure seems to this point aligned with the prognosis of advanced metastatic lymph node disease and should be avoided any effort that will preclude other therapeutic effort. Thank you so much. I will want to thank Dr. Vicky Kapoor and all of you colleagues from India. I've been very impressed by the organization of the conference, and I hope to see you soon.
Thank you, Dr. Eduardo, for being online, although I know it's very early morning for you. So we will have some discussion, but in case you want to make some additional comments, please come in.
Okay, thanks so much.
So your comments, please, first.
Mine?
Yes. Have you been listening to the discussions till now?
I mean, in case you want to add anything before we have the House to discuss.
Yeah, I think one of the points is very specific that we haven't mentioned because of most of the study that we provide are coming from countries who don't have a high incidence of gallbladder cancer. I would say in countries when we have high incidence of gallbladder cancer, maybe this taking laparoscopy does have a role, and also there is also a specific role to avoid unnecessary diagnostic instrument, and I think staging laparoscopy in the context of taking the patient to surgery is one of the steps, and I shouldn't add as much as we think it could be add to the cost of the healthcare to have a PET-CT in every patient. So we do have to understand that there are countries who the PET-CT is not widely available, and the recommendation should appraise all those situations.
Thank you, sir. Dr. Saurabh, you aptly discussed almost all the literatures regarding in this subject, but I'm not sure whether I missed the article published in 2023 by the Netherlands groups.
Yeah, Van Duren group. That's what I was
you
discussing.
discussed. So
Total 107 patients.
Yeah,
of
when the
IGUs.
yield of getting a malignancy on laparoscopy is so low, it's about 2 in 47 patients, and when you open, you can detect further 7 patients. So is it prudent to do a laparoscopy in these patients, or we are looking at 2 subsets of patients, one where we are suspecting dissemination on imaging, suspecting, not confirmatory or very clear, and second, where we are not at all suspecting? Can there be 2 groups and we can discuss separately
Yes,
for
there
them?
can be 2 groups actually.
Second, the PET scan, my PET scan colleagues say that it is only positive when the tumor size is more than 1 centimeter. And what about those cases where it is less than 1 centimeter? And do you think a patient who was operated laparoscopically a month or 15 days back for a laparoscopy will have liver metastasis within 15 days, and on laparoscopy will find them?
So, addressing the first question actually, staging laparoscopy as of now has actually become a part of the surgery itself. So it kind of forms the first part of the surgery, the first part being staging laparoscopy. So if there are 2 patients in which only on staging laparoscopy you found out the metastatic disease, those 2 patients you will avoid laparotomy. That does not mean that these patients cannot be subjected to laparotomy afterwards. The negative patients, the patients who actually turn negative on laparoscopy, are actually patients who are going to be resected, or you are going to try to resect. So in those further, if 7 more patients come out to be disseminated, so at least those 2 patients would benefit by avoiding the negative laparotomy. So that is the subset 1. Second, the Van Duren paper actually takes care of few factors like bile spillage. Actually, Van Duren paper itself says that our negativity or limitation is that the patients usually landed with them after about 70 to 75 days. So which was very long waiting period, and somehow, I don't know why they did not find this much of metastasis per se in laparoscopy. But the second thing is biology. So, the second question was for? What was the second question?
I said, is it prudent to do a laparoscopy in a patient who was undergone laparoscopy 15 days back or 20 days back? You have seen everything. And
as Dr. Shivendra Singh pointed out, that you may apparently not see metastasis, but there could be metastasis at the hidden areas, 1. Second, if you employ modalities like a laparoscopic ultrasound and all, there also you will be able to pick up some degree, some metastasis. Even Van Duren himself postulated that we should use LabUS if possible wherever it is available. So our main focus should be to rule out a disseminated disease at the outset itself, so that the patient is not subjected to an unnecessary surgery.
So what is the chance of getting a dissemination when there is no suspicion of dissemination on imaging at all, even if you do a PET scan?
Even if you do a PET scan, still, again, quoting Shivendra Singh sir's paper, 10 to 15% patients will still have dissemination. So this is across the table. Like even the studies that I quoted, they also found out that even after negative PET scan, at least 5 to 10% patients will eventually turn out to be metastatic. Yeah. So they will be the patients which will be actually benefited by staging laparoscopy. And actually, the PET colleagues of ours are now actually advocating the FRP PET as the different modality that they are going to employ. So they say that probably they are getting better results, but as of now, no studies are there for that.
So the second factor is the locally advanced nature of the disease. the resectability. So that is also one factor you can see in diagnostic laparoscopy. Yes, Dr. Vega, please.
Yeah, Dr. Eduardo, you want to say something?
Yeah, thanks so much. I don't know if you have the same experience or you have the same experience, but some of the conversation that we have about whether we do staging laparoscopy is really driven by whether we have some bile spillage or do we have a bad cholecystectomy with multiple perforation during the cholecystectomy. I found in my own experience that the operative report that I got from the surgery is actually not describing as would it happen the surgery itself. And I certainly, if we're gonna take a decision whether we're gonna do or not staging laparoscopy due to an operative report, I don't think it's reasonable that we have enough trustful evidence to say that first hasn't done any spillage and second hasn't done any perforation during the surgery. I understand that the subgroup analysis of the poorly differentiated pathologic risk factor is important, and I think I do agree that those are the patients who do have the most to gain with the staging laparoscopy, but that doesn't mean that we are not going to find significant difference from what we were expecting in an early gallbladder cancer than what we found in the surgery. And the second question about why would you do a staging laparoscopy if you just did a cholecystectomy? Well, because the cholecystectomy, at least in United States or in Chile, are done by general surgeon. They're not done by hepatobiliary surgeon. They're not done also by people who are used to see micrometastasis in the liver or a small carcinomatosis, and they usually pass that without any finding. So I wouldn't trust the decision making of the acute cholecystitis because for some reason that I could not explain, we usually focus ourselves in only the gallbladder we're gonna take out.
Yeah, I was going to say the same thing. Let us put a hand on our heart and say how many cholecystectomies I have turned the telescope all around the peritoneal cavity and looked for a metastasis in a patient with gallstone disease. Even we don't do it. How do we expect our general surgeon who's doing 5, 10, 15 cholecystectomies in a day to do that? So I don't think that argument should be used. My question is to Shivendra. You said you do a staging laparoscopy before you put the patient on neoadjuvant therapy, but then that means you repeat it when you take the patient for surgery? Yeah. So that point again, the group which is Saurabh, you have to make a note that if the patient is receiving neoadjuvant treatment, the patient will need 2 staging laparoscopies.
Since we are looking for advanced disease, should we be talking about tumor markers like CA125,
Yeah.
CA99? Because if we
Exactly what I talked in the first slide, that initially requires actually a extensive workup in a neoadjuvant patient in terms of CA99, FDG PET, all kinds of imaging.
125 as well, because that's more for peritoneal disease.
Yeah.
If you have two
Actually, I am doing a study on CA125, 15.3 and all in CA gallbladder, and we are finding that they also predict CA gallbladder.
So Saurabh, the evidence is obviously not very high level, and at present we can say that these two are complementary, the diagnostic laparoscopy and the ancillary investigations. So this much we can say. We will discuss all the points later on during our dinner or something. So we will move on to the next step, please, sir.
Thank you.
Thank you, Dr. Eduardo. Thank you very much for sending the video and joining online also very early in the morning. Thank you very much, and hope to see you in Jaipur next year.
Will do.
Thank you.
Bye-bye.